So welcome guys. So we've got the final Crash Course series. So it's our final session on infectious diseases by Dr. Adrian Crawford up here. So we have our Instagram QR code up in the top right corner, and in the bottom left we've got our email address as well. If anyone has any questions or anything, please do email us. And if anyone's interested in getting involved in teaching at all next year, also email us and we can always get something sorted for you guys. Cool.
No problem. All right, let's get cracking. Hello guys, hi, I'm Adrian, one of the junior doctors at Basingstoke Hospital, ex-Georgia student. So tonight we'll be going over very sort of like briefly, straight to the point, quite succinct, some of the infectious diseases topics. They're just primarily sort of adult based, and I think there's quite a bit on pediatrics that's not in this session. If you do want something like that, we can do it informally without slides, just a bit of a chat. Maybe it's some other point that's suitable for most people if you just message in the chat or email or something. So we won't cover stuff like croup and like RSV and all that kind of stuff, but we'll cover a lot of the adult related infectious diseases, and hopefully you'll find some of it useful. It's going to be very interactive, so do try and use the polls and interact and do ask questions at any time. All right, great. So we'll start with the first question, and then we're going to have a set of questions, and then we'll basically have the slides. So I'm going to open the poll. So if you read the first question and then try and give an answer. I assume the poll is working. If it's not working, do let me know. Cool.
It's working for me.
Yeah, for me too. So that's good. So we'll give it another minute or so. So you've got 6 answers, 8 individuals. Right, I think I'll stop the poll. Do I stop the poll and show results, or do I just stop?
You can do both. So if you stop the poll, show the results, they can see it on the phone, and then you can go over the answers as well.
All right, cool. So I hope you guys can all see the results. So most people, this is my first time using this VBox, so hopefully it's all working okay. Ash will let me know if things are not going according to plan. So most of you chose C. So most people chose C, which is drug-induced neutropenia. And, you know, maybe just one person by the looks of it, a minority chose B. Now, I'm not sure if it tells me on the next slide, I can't remember. But in this case, the correct answer is B. And this is going to raise some eyebrows. It's the single best answer. Now, of course, when we look at this question, we know that C is correct to an extent because of clozapine, okay? And most of you who have studied for your PSA would have come across this. It does cause drug-induced neutropenia, but let's look at this in a very systematic way, and then we'll have a look at what sepsis is. So we've got this person who's 52, they started doing clozapine, they're feeling a bit under the weather, and the typical example given in the sort of PSA books or any textbook is they start to have like even a sore throat or something like that. They've got a temperature which is 38.2. The neutrophils are a bit low, the lymphocytes are low, the hemoglobin is low, that's a red herring, and the CRP is high, which you obviously know is an inflammatory marker. Now, the likely diagnosis in this case is neutropenic sepsis because they've got a high temperature and they've got a neutrophil count less than 1. Yeah? Some texts might say less than 0.5, but it's less than 1. And that is because of the drug clozapine. Now, you can get drug-induced neutropenia, but just imagine a patient come into your clinic, or you clerking a patient, and you realize they've got a low neutrophils, and they're on clozapine, but they're not feeling ill, or they're not septic. Then you have a chance to stop that drug, which is why they have increased monitoring of patients who are on clozapine in the beginning. So if you see things going down, then you can stop the drug. In this case, this patient's already septic with a high temperature, a high CRP, and the neutrophil count is quite low. That's why the most correct answer is neutropenic sepsis. Yeah? If you do have any questions, feel free to type it in the chat and do ask about it. So what's sepsis? So obviously you guys know it's an inflammatory response systemically, okay? And the key signs is a high heart rate, high rest rate, you get a low BP, a high heart rate in response to the low BP, and of course increased temperature, okay? And then you have to think, if someone's going to be neutropenic, or if they're on any sort of like immunosuppressant drugs, they might not mount that typical response, right? So some of the questions they'll ask in the exam, they might not ask you specifically about septic cysts, but they'll expect you to kind of have some idea. They'll give you a question with some clues, and then you'll need to decide what's the next best things to do. And so as long as you remember that you've got 3 tests and 3 treatments, some people will say 3 in, 3 out. Whichever way you can remember it, that's fine. And, you know, that's taking a lactate, either by VBG, ABG, blood cultures, and monitoring urine output. That's the 3 tests, or the 3 things that's out. The 3 treatments, or the 3 things that you're going to put in, oxygen, if it's required, okay, and aim for 94 to 98 or 82 to 92 in COPD. Antibiotics, if you can figure out a source. If you can't figure out a source, then it's just antibiotic for sepsis of unknown origin. You can find that in like microguide or any other thing. And then fluids, okay, because obviously if they're having a low BP, and you know, the systemic inflammatory will just cause like vasodilation, so you can use fluids to help. And the question that we looked at discussed neutropenic sepsis. Okay, now the criteria for neutropenic sepsis is a temperature greater than 38 and a neutrophil count that's less than 1. Okay, and it might give you a clue of someone like the question I gave, someone on clozapine, or someone who's having chemo, or someone who's on some kind of like monoclonal antibody drug or whatever, right? So that's the key thing to look at. So that's sepsis, all right? They'll just give you a chart, they'll give you someone feeling unwell, high heart rate is often the first sign, rest rate, often the first sign, and then you'll see all the other systemic responses, right? Right, let's move on. Question 2. I'm going to open this poll, and hopefully things are working correctly. Cool. I think most people have answered, so we can stop the poll. Oops, I think I just about, one person just about made it. Okay, so I can see it's a decision here between A and B. Okay, so let's start by crossing out the ones that it's less likely to be. All right, it's less likely to be. In fact, let's go over the answer itself. The answer is A. Okay. So it's going to be strep pneumonia, but let's kind of cancel out why it's strep pneumonia. It's unlikely to be Staph aureus, because Staph aureus is basically mainly found in the skin. Yeah, obviously it does get in the body, but it starts off in the skin. It's less likely to be Pseudomonas. Okay, Pseudomonas is normally found in a number of other areas. And you usually get this in patients who have cystic fibrosis. So Pseudomonas and also Staph aureus, you can get that in patients who have cystic fibrosis. So if the clue was someone who had cystic fibrosis, you could think, okay, it could be Pseudomonas. Legionella, if there's going to be a question in the exam about Legionella, it's going to be about someone who went on holiday and stayed in a hotel. Legionella is generally from sort of like air conditioning units or from water, yeah, so like showers that are not treated properly, etc. Those of you who used to live in halls, I used to live in halls back at uni, they used to come and like do this kind of like shower maintenance thing where they turn the water up really hard and treated it and all kind of stuff. That's just to prevent Legionella, right? It could be Haemophilus influenza, definitely. So Haemophilus influenza is a cause, but strep pneumonia, Streptococcus pneumoniae is the typical response. It's the typical answer that they're looking for. And, you know, pneumonia is in the name, but that's a typical response, yeah? Right, let's look at question 3. Can see a couple of people changing their minds, so I'll give it another minute or so. Okay, cool, let's move on. So if you didn't get time to answer, but I'm just mindful of the fact that people do need to sort of study after this, so we want to keep it as succinct and brief as possible. Now, the majority of the answer, most people selected B. I think it's a toss-up between A and B, and it used to be that for me, and even now for most people, it's just a real toss-up. Now, the answer for this is B, okay? When you're looking at a dipstick and you're looking for a true indicator of a UTI, we're not really concerned about the pH. We're not really concerned about the glucose. Yeah, blood could be one of the things that show up. But if we're going to be treating this and giving them antibiotics, the true answer, nitrates, okay? That's a true indicator. And yes, leukocytes do show up as well. Now, leukocytes are obviously just white blood cells, okay? And the nitrates is basically what's converted from nitrites by the E. coli bacteria. But we'll look at this briefly in terms of looking at some body sites and the typical infections, all right? So we just spoke about the chest, like 50% strep pneumonia. If you see in the exam anything about chest infection, which bug could it be? It's almost likely to be strep pneumonia, yeah? Apart from obviously we spoke about atypical from holiday. This is a nice one that they could use to try and decide or separate sort of like people. Someone who's a farmer, the answer for that would be Q fever, yeah. And someone who has contacts with birds, so like a bird keeper or something, then it's chlamydia stasi, okay. And the typical treatment is amoxicillin. They usually don't ask, I don't know, but if they do, just go for amoxicillin. In practice, you just follow your local guidelines once you're qualified, or just use microguide. That's pretty much what I do. Over time, you'll get to know it. Urinary tract infection, like literally 90% of them, E. coli. Yeah, if they ever ask you what bug do you think it's going to be, it's going to be an E. coli. E. coli is a gram-negatives, so they're gram-negative RUDs, and they break down nitrates to nitrites, and so that's why you do get that in your dipstick, all right? And the treatment is either trim or nitro, depending on the local area. and the resistance. Generally 3 days in women, 7 days in men, or if they've got like complicated urinary tract issues, then you go for 7 days as well. A couple of caveats that you really must try and remember, and of course this is recorded, so you can always go back and look over this or take a picture. Someone who's pregnant in an exam question who has a UTI, always remember to look at what trimester they've mentioned. If it's in the first trimester, you want to avoid trimethoprim because it's a folate antagonist. If they're in the third trimester, then you want to avoid nitro because it can cause what's called like, hemolytic anemia in the newborn. So first trimester, forget trim. Third trimester, forget nitro if the patient is pregnant. All right, cool. Let's move on. Question 4. I'll give it a couple more minutes, or rather a minute. Right, we're still waiting for a couple more responses, but I'm going to stop the poll now. Okay, so everyone, those who've answered anyways, went for B. Yeah, so Neisseria, gonorrhea. And I think the clue here is that they are young, yeah, and that they are sexually active. Okay, so Staph aureus is a common cause, but Neisseria is also a very common cause of joint infections. Okay, it's not going to be group A strep. Yeah, that's more sort of like oropharynx. Gout is not a organism. Yes, just a diagnosis. Crystals. Yeah. And it's not going to be Pistache, chlamydia, because that's for people who sort of keep birds. Right. So skin and soft tissue, cellulitis, Staph aureus. Yeah. Almost always go for Staph aureus, and the treatment for that is fluvoxacillin. If they're pen allergic and penicillin allergic, then you can give them clarithromycin. Yeah. For joint, so septic arthritis or recent joint replacement, Staph aureus is your common cause. Whether the patient is young, sexually active, and particularly if they tell you that it's a gram-negative diplococci. Yeah? So gram-negative diplococci are basically like that. Yeah, gram-negative diplococci. I'm sure they won't give you an image of it, but they'll just explain gram-negative diplococci seen on the gram stain. Just say that's gonococcus. That's definitely Neisseria. Cocci means circular, yeah, like round. So diplo, 2 rounds, okay, and gonococcus, strain, same like staphylococcus, streptococcus, they're all round. But that's the answer you got from. The treatment is again fluvoxacillin. So tissues, skin, joints, anything that's growing Staph aureus. If they do ask you about treatment, just think I could try fluvoxacillin unless they're allergic to penicillin. Then you can go for an alternative like clarithromycin or clindamycin. Okay. Question 5. Please. Okay, I can see one or two individuals changing their minds. So I'll give you some time to think about this. Maybe just another few seconds. If you do want to choose an answer, choose one now, because I'm going to be closing the poll in a minute. Okay, let's start. Right, so majority of individuals chose B. Okay, so it's between B and A. Between B and A, which I think is very good that most people went for B and A. So the correct answer in this case is B. And there are some key things to pick out here. So, okay, they've got watery diarrhea. That could be anything. It could be Salmonella, it could be Bacillus cereus, it could be Shigella, it could be E. coli. Okay, so we've ruled out adenovirus. Well, it could also be adenovirus, to be fair, so we can't really rule that out, but it's kind of like less likely. But it happened after eating leftover fried rice. Okay, so leftover fried rice, that's a big clue. Yeah. One thing you'll find with the exams, they're very kind of like stereotypical, so it's generally just like they play on certain kind of themes or stereotypes, and you just got to pick those out and just run with it. It was kept at room temperature, and the key thing here, the symptoms completely, I tried to correct that, completely resolves within 24 hours. And if the symptoms completely resolve within 24 hours, and you know it was rice, and they had watery diarrhea, it's going to be Bacillus cereus, okay? Gram-positive, right. Let's go through this. So gastroenteritis. Viral causes, so rotavirus, norovirus, adenoviruses. I know I did say it's less likely in the last one, but it does cause that. You get rotaviruses quite common in children. Norovirus is quite common in terms of an outbreak. One thing that comes up in the exams, and I remember this one coming up at one point, was about Campylobacter. And Campylobacter, the key thing I want you to remember is that it only grows at 42 degrees. It's one of the few bacteria which will be incubated purposefully at 42 degrees, because that's the optimum temperature. And the reason that is because it's generally from poultry, or if you want to say quote unquote birds, and birds are quite warm, they're quite hot, and so generally they use that incubation of 42 degrees to try and mimic the normal environment. And so you might get something in the exam about someone who either traveled or had undercooked meat or something, and then the sample was taken, the stool sample was taken, and was grown in the lab at 42 degrees C. What's the most likely organism? It could be anything, but because they've told you it was grown at 42 degrees C, you know it's Campylobacter, yeah? So we've got some of the key things to think about in terms of toxins. I can't remember if I got anything now. Some of the key things to think about in terms of the toxins is the 0157 from E. coli. That can increase the risk of uremic syndrome, hemolytic uremic syndrome. The same with Shigella toxin. So if someone's got E. coli 0157 or Shigella, it's likely you need to test for the toxins. And Bacillus, which is what we just spoke about, also produces toxins, and it typically resolves in 24 hours. Okay. The thing about the exams, it's about picking up key phrases. Okay, we know Salmonella is common for gastroenteritis, so don't miss that. All right. Contaminated water, contaminated food. We know E. coli is common for gastroenteritis, contamination. Okay. So if you get something that looks obviously to be either Salmonella or E. coli, go for it. But if you get key things like 42 degrees C, or they were given antibiotics and then suddenly developed HUS, then think, this could be a toxin, either E. coli 0157 or Shigella, all right? Or if they told you that the diarrhea just miraculously resolved within 24 hours, think, this could be a cerulide toxin, so it's probably going to be Bacillus, especially if they said something like rice or something like that. All right, cool. Question 6. Let's see. This is interesting, the results of this one so far.
I'm not sure if you can see what there is a question in the chat.
Oh, really? No, I haven't been looking, sorry. Let's see what this question is. Chat.
I can read it out if you want.
Oh, farmer's lung. That's Coxiella. I think they're talking about Q fever. We'll look at that afterwards. I think we spoke about that earlier on, but we'll go back to that after. We'll finish this poll, and then we'll go back for that. Let me just start this poll. Okay, great. So this is a good mix. It's a split between A and B, which is a good split. I think the key thing here is just remembering which one's the most common. Okay, so most common in both children and adults, it's going to be both of them. Okay. And I think this is a very, very good split, and it's unlikely to be any of these three. Okay, so Neisseria meningitidis and Streptococcus pneumoniae, right? They're two of the most common in both adults and children. So let's look at this. We'll do this. I won't forget the farmer's lung question. We'll go back to that, right? So meningitis, so bacterial causes and viral causes. Now, bacterial causes are generally quite severe. Viral causes are generally quite mild. Okay, so the two commonest causes, which we just looked at in both sort of adult and children, we're looking at meningococcal, and pneumococcal. Now, people sometimes get confused because of the name meningococcal and pneumococcal, but it's literally Neisseria meningitidis. It's just meningo. People just do it like that. And Streptococcus pneumoniae, pneumococcus. Yeah, so it's basically the same thing. Neonates. This is a nice one to remember for neonates. Okay, for neonates, the most common cause is Group B strep. Okay, Group B strep. Now, the reason that it is Group B strep is because mothers, especially if they're delivered by vaginal delivery, women can carry Group B strep as normal vaginal flora. Okay, some hospitals do screen for it, but some hospitals don't bother because they're like, it's just vaginal, it's vaginal flora. And so we'll be literally swabbing everyone. But some hospitals actually do screen mothers for this. and then treat them if they do have it. And so if a baby is born by vaginal delivery, they're more likely to pick up Group B strep in a carrier of Group B strep, and so they're more likely to then have GBS, meningitis. So treatment in the community is Ben-Pen or Pen-G. In the exam, it will put it down as like something like benzyme penicillin. So they won't put Pen-G or Ben-Pen. And in the hospital, we just go for broad spectrum. Okay, so some kind of cephalosporin. So if they're greater than 3 months, you'll go for ceftriaxone, and if they're less than 3 months, then you go for ceftaxin and amoxicillin. And the amoxicillin is to cover for stuff like listeria, which can cause meningitis as well, right? Viral causes, HSV, enteroviruses, VZV, those are your typical causes. You generally don't treat them, it's just mild, supportive. But if it became severe, then you can give them some acyclovir antiviral, right? Cool. ENT. So before we do that, let me just go back to, I think someone's asking a question about Coxiella. So we spoke about chest infections. So if someone presents with a pneumonia type picture, we think about strep pneumonia. Okay. Obviously, there's another infection now which we need to think about, which we'll come on to later on. If they went on holiday, hotel, that's the key word. Then you think about Legionella. So Legionella and pneumococcal, they're like atypical. Yeah. But strep pneumonia is a natural bacteria. Legionella and pneumococcal are like these sort of like atypical kind of pneumonia. It's different. They call them atypical because it's difficult to grow in the petri dish. Coxiella burnetii, or people call it Q fever. So you might get a guy who's like working on a farm or something like that. If they did say something like it was identified in the lab as some kind of like fungus, and the person works with hay or something, then you can think maybe it could be like aspergillus or something like that, right? And if someone's working with birds, then chlamydia and psittaci. Yeah. So Coxiella burnetii, that was the thing we looked at. Let's see if we can crack on. And by all means, any other questions, do put them in the chat or let us know. Right, ENT stuff. So commonly caused by viral infections, and I would definitely recommend just having a quick read over for pediatrics. They generally present a sort of like coryzal staph, cough, all that kind of jazz. So just quickly read over that. So NICE recommends a delayed prescription in the community, and if it doesn't settle after 3 days or so, then you can give them some treatment. The commonest causes for tonsillitis, the commonest cause is strep pyogenes or Group A strep. Right? So that's one thing to remember. And the criteria for that is someone who has mainly exudates and the tonsils of the anterior cervical lymph nodes are quite tender. That's basically what you're looking for. Yeah. So yeah, they might have some fever, but if they're really poorly, they've got exudates, they've probably got a strep pyogenes or Group A strep, and you can give them Pen-V. Yeah. Now Pen-V is different from Ben-Pen, all right, which is the one we spoke about here. So Pen-G or Ben-Pen, so benzyl penicillin, is what we'll use if we think someone's got meningitis in the community. Pen-V, phenoxymethyl penicillin, is what we'll use if we think someone's got bacterial tonsillitis, all right? And otitis media and sinusitis, if we think it's bacterial cause, it's more likely to be strep pneumonia. If you think it's coming from the sort of respiratory area, and going up into the oral sort of like mucosa, and then going into sort of that region. That's typical cause, right? Let's see if there's another question. Yeah, there is. Let's go to question 7. We'll just give it a few more seconds. Okay, so I'm going to stop the poll now. Cool. So this one, question 7, is about you've taken a CSF sample, and these are the results. Now, I wouldn't worry too much about the numbers, because different labs will have sort of different values and different cutoffs. So don't worry about what normal is, etc., etc. Just look at how the numbers compare to each other. Yeah. So if they give you, say, if they tell you in the exam that this is normal, yeah, then you're going to compare whatever the result they gave you to normal. The first thing to do, and this is how I decide how to select the answer. First thing to do is to look at the appearance, or figure out the appearance of whatever the sample was. They'll say the sample was taken, it was noted to be clear. Okay, so it's clear. So that's making me think viral is more likely. Yeah. Then the next thing I do is I look at the protein, and I look at the glucose, and then I look at the white blood cells. That's just me. Other people might do the other way. Like look at the white cells and look at the protein and look at the glucose. Whichever way you prefer, it doesn't matter. But just try and think about it in a logical way. If you have bacteria in a CSF sample, chances are, in order for the bacteria to survive, it's going to try and use up the glucose. So the glucose is going to be low. Yeah. Obviously, again, if there's bacteria in the sample, it's going to present higher in terms of number of proteins. Okay. So therefore, the protein is going to be high. And obviously, it's going to cause a huge sort of neutrophilic or polymorphic response. So the white blood cells will also be high. Yeah. So just think, if I'm expecting a bacteria, they're going to use up the glucose, it's going to be low. The protein, obviously their protein, it's going to be high. And if it's a viral, well, okay, the protein's going to be fairly low, and they're not going to use up that much glucose, and the white cell response is not going to be that high. And of course, viral meningitis is generally milder because the response is generally less intense, right? So that's correct. So the row B, this row here, right? Great. So question 8. Okay, I think I'm going to close the chat. Right. So I think most individuals chose A. And of course, if you do have any issues, guys, if the slides get stuck or you can't hear me, do let me know. So obviously the answer is A, and the keyword is ZN. Yeah. So Zeal-Nielsen. Yeah, ZN. Once you get that, ZN and acid-fast bacilli, it's always going to be TB, just almost always. And like I said, the questions are very stereotypical. So it's never going to be some like Spanish guy with a cough or something, even though we know that that is the case. Like anybody gets TB. But the question is going to be so stereotypical that they're going to make it like, you know, some guy coming from some foreign country in the developing world or from Eastern Europe. Yeah, those are the two people group they choose. And then I'll say like acid-fast bacilli, ZN. You just got to just accept it, run with it, and say, okay, this is what they're pointing me to. Let's just move on. Yeah. So key things to remember, you know, this is a revision session. You guys would have studied most of this. So just key things just to help you to pick out when it's time to do the exam. So acid-fast bacilli, yeah, so it's rod-shaped. They might give you some tests and then ask you to interpret what's going on. So if the MON2 test is positive, it either means that they've been vaccinated, that it's either latent TB, so they've had it in the past, or active TB, right? So you do the MON2 test, and if that's positive, then you can do the interferon gamma, yeah, so the IGRAs. And if that's positive, then it confirms that it's latent TB, but not active. For active TB, so you might do the interferon gamma test, but you also might take a slide, a sputum sample, all that kind of jazz, and that's how you'll know it's TB. Yeah. Latent TB, if they're healthy, you normally don't even bother treating it unless you think, oh, there's a risk that this person's TB could reactivate, such as like if you're going to put them on like an immunosuppressant or something, right? So in that case, if you think there's a likely that this could flare up again, you can give them isoniazid and rifampicin for 3 months, or just isoniazid for 6 months. Okay. The one you really want to remember though is the acute TB treatment, and the one that everyone always remembers in med school is RIPE. Yeah. So I remember it as RIPE 6622, because if you just remember RIPE, okay, you know what you're given, but you might not remember how long. So that's why I put the power of sixes and the power of twos, because that's how I remembered it. Yeah, RIPE 6622. Yeah, that's your kind of formula. So it's rifampicin, isoniazid, both of them for 6 months. Yeah. Pyrazinamide and ethambutol for 2 months. Okay, so first of all, you're going to give all of them. You're going to start all 4 of them in one go, and after the first 2 months, you're going to drop off these 2, and you're just going to carry on with the RIF and the isoniazid. Yeah. Now I've got rifampicin in like an orangey color, just to remind you that you might have something in the exam where someone started on an antibiotics and suddenly their tears are orange, their pee is orange, like the body fluids just look a bit odd color. Just know it's going to be rifampicin. All right, that's the key thing to remember. Cool. HIV. This is also a good one to kind of be able to recall. Obviously, you know, it's a retrovirus and it destroys CD4 T helper cells. Okay. The main thing with this is remembering about the CD4 count when it comes to monitoring. And the key number you want to remember for HIV is 200. Okay. If you don't remember anything, just remember CD4 count of less than 200 means trouble. All right. And it means trouble in the sense that the patient's more at risk of infection. Okay. So if someone's got a CD4 count of less than 200, it comes up with a barrage of problems and things that you need to think about. Pneumocystis pneumonia. If you get someone who is HIV positive, CD4 count less than 200, think of PCP, okay? They're presenting with pneumonia-like symptoms or cough or chesty symptoms. And the treatment for that is generally Cotrim, cotrimoxazole. And you'll normally give them that as a prophylaxis anyway, someone with CD4 count less than 200. After CD4 count, the other thing you want to remember is also viral load. Yeah, viral load. That's quite important. If you get something in the exam where it says the viral load is undetectable, that's excellent, all right? Because it just means that transmission is less likely in unprotected sex, that mothers can generally breastfeed as normal, and that vaginal birth may be considered, all right? If the viral load is high or detectable, so usually greater than 100 normally, then you really don't want mothers to breastfeed, and you really don't want them to have a normal vaginal birth. You want to go for C-section. And the treatment for this is ART. Yeah, so the HA is for highly active antiretroviral therapy. And so you want 2 of these, I think NRTIs for like nucleotide something, trans something, I don't know, you can look at it, I can't remember. You want 2, based on these guidelines, 2 NRTIs plus a third agent, all right? So that's what you look for, HART or ART. Just also remember, isn't so much, well, PEP, you can remember PEP as well. Someone who had sort of, could possibly have some transmission, either due to being in contact with blood products or through unprotected sex. Ideally, you want to give that within 72 hours, okay? And PrEP, which isn't really treatment, but it's like a prophylaxis. So it's 1 tablet, and you'll give it to high-risk groups, such as men who have sex with men, as they say in the textbooks, or other high-risk group, people who are at high risk, maybe people working in the sex trade, etc. Right? Malaria. When it comes to malaria, there's one thing you really want to remember, and that's Plasmodium falciparum. Yeah, that's like 75% of almost all the cases that come to the UK. Okay, over 75% of all the cases that come to UK. Right? So you could either have someone who travelled to an endemic area, or someone who had like malaria years ago, and now it's just like kind of like flaring up, right? And they would have travelled usually any time like a week to 4 weeks ago, and that's generally the incubation period. That's all I'm going to say about malaria in terms of the one thing that it's just the most severe form, and it's the commonest form, right? So let's look at question 9. I'll open this up. And I think this is the last question. Yeah, last question, and then we'll start wrapping up. You can see lots of people changing their minds. This is probably by far the most interesting poll. Is there a question in the chat? Let me see, my phone just buzzed. Ah, cool. This was, oh really? Ah, cool. There's a question on my final SBA today. So let's see. I think we can close this. Let's close this. So this is quite split. So majority went for A. then we had some went for C and some went for E. Now, the answer is A. So it says here active, okay? And we'll have to look through this because this can trip you up big time. They test you on this Hep B thing all the time because it's so easy to trip you up. Okay, so Hep B surface antigen, okay? Let's look through the reasoning and then we'll come back and look at the question and go through it. So in hepatitis B serology, the two things you want to first look at is a Hep B surface antigen and the Hep B core antibodies, okay? If the Hep B surface antigen is positive, that means a person currently has an infection, okay? Now, we need to know if this is an acute infection, and we can do that by looking at the Hep B core antibodies. And when we look at the Hep B core antibodies, it'll pop up positive, and we'll then be able to look at the IgM or the IgG and decide whether it's an acute, so IgM, or if it's a chronic. So I usually remember it like IgG, so G is for ago, so long time ago. And if it's IgM, obviously it's acute. So the Hep B surface antibody, which is HBsAg, can either mean that you have an infection, but it could also be that you're vaccinated, okay? So this is why it's not really the best answer, okay? Because it could be that you're vaccinated, or it could be that you've had it, okay? When it comes to the E antigen and antibodies, anything to do with E is to do with the acute phase of the infection, okay? So if your Hep B E antigen is positive, that means you're highly infected. So at this moment you're shedding, you can just infect other people. By the time you build up antibodies to the E antigen, you've passed the acute phase. So you've had this infection, but you're no longer so acutely infected that you're shedding this infection. You're not that highly infected, which is why we can get rid of E altogether, okay? So to indicate that someone has an active Hep B infection, we're now stuck between A and B. And they can both tell us, but A is more correct because it's the surface antigen, it's the surface antigen of the actual virus, so you have that infection. The core antibody could either mean that you had it in the past or you currently have it. So you have to choose one. It's going to be the surface antigen. So whenever you're screening for Hep B, you want to start with the core antibody and the surface antigen. And if positive, then you check for E antigen to see if they're currently shedding or if they're highly infective, because you need to tell this person to kind of like lay low or chill. And you also look for the viral load, right? I hope that's clear. Right, and I think this is the last slide, if I remember correctly. Just to go over COVID. Let's just see. Did that cool. Last one. COVID. It didn't come up in my year. Didn't come up in Ash's year. This thing is still, we're still learning. It likely could come up in your year. They're not going to ask you anything crazy because even the experts are still learning about this thing. But what they could ask you is to diagnose someone with COVID. They might not ask you so much about the treatment, but to make a diagnosis that this likely could be COVID. So they're going to present like someone with a pneumonia, okay, shortness of breath, temperature, that kind of stuff, you know, cough. They might say it's a non-productive cough, but that's beside the point. There are two key tests that you should be looking for, two things that they might mention in the question. And the first one is a procalcitonin. And the procalcitonin is literally like if you take a CRP, yeah, the CRP is sort of like an acute phase protein. It tells you that someone's got an infection, but it's very non-specific. You know, it could be viral, it could be bacterial, it could just be trauma. You know, it could be post-up. You know, someone might have had a car accident, broken bone, whatever. The difference between this and the procalcitonin is that procalcitonin helps you to decide whether the rise in CRP is likely to be due to a bacterial or a viral infection. So what's going to happen is you're going to get raised CRP, you're going to get raised white cells, particularly neutrophils. We'll come on to lymphocytes in a minute for COVID, okay? And now you need to decide, is this bacterial, is this like, or sort of viral? If it's positive for procalcitonin, it's likely to be a bacterial, and therefore you're unlikely to be thinking about COVID unless the patient has a co-infection, okay? So if they got COVID and another infection underlying, then fair enough. In the COVID patient, you're going to get a negative procalcitonin, okay? And the lymphocytes are generally quite low. And that's what we find with COVID patients. They have low lymphocytes and negative procalcitonin test, okay? And they present as pneumonia, all right? The sodium might also be affected. So the treatment for this is obviously you follow local guidelines once you're qualified, but just know this. If they're admitted and they need oxygen, it's giving you a clue as to the severity, okay? If they don't need to be admitted to oxygen, they don't need oxygen, then it's not that severe. So that's giving you a clue, yeah? So what you want to do is consider giving them a steroid, such as dexamethasone, and you usually give that for 7 to 10 days. Yeah, most people just go for 10 days, all right? Then you also want to consider remdesivir. It's what most people use now, yeah? So these are two things that most people do. We'll consider a steroid, and we'll consider an antiviral, okay? And what you can do is test for COVID immunoglobulins to see whether they've built up some kind of like antibody to this, or if they've had the infection in the past. Those are the key things you want to start with. You can then also consider giving them some monoclonal antibodies to help to fight this infection, all right? I doubt they'll ask you for this kind of treatment in a major way, but if they did ask, then you really want to give them a steroid such as dexamethasone and an antiviral such as remdesivir, right? So COVID, key things you need to remember, just to go over that again. First, if they do give you any test, it's going to be more likely a procalcitonin test, or they might give you full blood count with the whole CRP shebang, which means absolutely nothing, but look for the lymphocytes. And if the lymphocytes are low, then that's a bit of a clue. And if the sort of like sodium's all over the place, like out of range, deranged using these, that's also a clue. That's the first thing. And then the second thing you want to look at is, are they admitted and do they have an oxygen requirement? Oxygen requirement means that their SATs are below 92, yeah? So do they need oxygen? And if they do, and they're admitted, consider giving them a steroid, all right? Dexamethasone for about 10 days, and that should do it. And, you know, an antiviral, etc. Right, so that's basically it. We tried not to, I was trying not to go too intense or too deep, just a nice refresher. It's really broad, infectious diseases. And I hope you found that useful. If you do have any questions, by all, do email. Guys, reach out on Instagram, like, we'll totally respond. Just send a quick message or comment on something and we'll respond. And definitely do give some feedback. As I said, if anyone's kind of like freaking out and they do want to go over anything, just give us a shout. I'm happy to go over it again in an informal setting on Teams, without slides, just a general chit chat. And if you do want to go over any like pediatric stuff, then definitely do let us know. And I think Ash is posting the feedback forms. Like, we'd absolutely 100% appreciate if you can literally fill them in. Ash, do you want to say anything about that? Let me put up the QR code thing. I don't know why this thing is playing up like crazy.
That's fine. There's nothing more I can add. Yeah, thank you, Adrian, for doing the session.